Welcome to the Who Knows This podcast, where I track down in the trenches experts to answer questions that we all want the answers to. I'm Sam Visnic, and I'm a veteran in working with people with chronic aches and pains by way of massage therapy, exercise, pain education, hypnotherapy, and lifestyle education. Today we're going to talk about the ALF approach and how it's helping to change the way orthodontics is done. So let's get started. Okay, so I'm going to read a brief bio here so you know who our guest is. Her name is Dr. Tasha Turzo DO. She graduated from Western University, Pomona, California in 1994, where she received a postgraduate osteopathic manual medicine and anatomy fellowship. She's a clinical adjunct assistant professor at Touro College of Osteopathic Medicine, where she has been a guest lecturer since 2007. Dr. Turzo has also been co-treating patients and working monthly with Dr. Nordstrom since 1995, who is the developer of the ALF appliance, and she's also a founding member of the ALF Educational Institute. Dr. Turzo is an internationally recognized expert in the application of osteopathy and functional dentistry, with a focus on the use of the Advance Lightwire Functional devices, ALF for short, and TMD. So let's welcome her. All right, Dr. Turzo, thank you so much for being here. And this is going to be an amazing topic. And I think for a lot of people, it's going to be a very eye-opening topic as something that I don't even know if most people have even heard about this, but it is a big one. So thank you so much for being here.
Absolutely. Thank you for the opportunity to share.
Absolutely. Okay, so right off the bat, I'm going to start with some big picture questions so we can kind of set the stage for some more specific things. And you are essentially what I would perceive, and you could correct me if wrong, but an expert at airway issues, right? And that's anything involving the cranium and the jaw and the mouth, because that's what you write about in your book. Now, that's a very specific discipline to go into from being an osteopathic doctor. What led you into this direction?
That's a good question. And let me just reframe it as a little bit of a bigger picture than airway. So airway is literally the space behind our tongue and in front of our neck, basically, that space. And it has been termed airway, and it's caught on with the dentist. And one of the reasons why it's so exciting for the dentist is because once they start to realize that what they're doing to the face and the teeth is affecting the airway, they started to get an integrative perspective of how large their changes and their process and their treatments are affecting the patients. So I don't think of myself as an airway osteopath or an airway physician because it's just a small collapsible tube, soft tissue tube, and it's all innervated. It's the soft tissue. So it's a much bigger picture than that. If I had to term it, I would say that I have an area of expertise within the craniofacial area, but as an osteopath, I am certainly treating the entire body with every single one of my patients. So it's really the growth and development of the face and the intraoral function that creates that space of airway. Meanwhile, I do lecture a lot within the world of airway. And what led me into this is actually a really great story. So I was quite young when I started my practice here in Santa Cruz. I kind of went like the preschool, kindergarten, all the way through medical school and, internships in the hospital. And then I did actually a 4-year program in Berkeley with classical homeopathy, which has been something that's been a great tool to be able to use in addition to my practice. And when I started my practice, I literally inherited the office manager, the tables, the artwork, the everything. And I saw on my paper schedule, because that's when we had paper schedules, it was once a month on Wednesdays was blocked out, and it had Nordstrom written at the top. And I thought, what is this Nordstrom thing? Like, do I get to go shopping at Nordstrom once a month? Like, are they, not that I'm a shopper at all, but it was confusing. And so my office manager at the time, who I inherited the practice from another osteopath, said, no, Dr. Derek Nordstrom comes to the office once a month on Wednesdays. And Dr. Derek Nordstrom is the inventor and the creator of the ALF appliances. So he had been connecting in with the osteopath that was there previously, who was there for 3 or 4 years. And when I came in, we started this once a month process. And he would come up and we would spend all day, sometimes into the wee hours of the night, working four-handedly with patients. And at that time, the appliances were still being developed. So I was the canary in the coal mine by putting my hands on with cranial osteopathy and kind of saying yes, no, in terms of the designs of the appliances. And we're looking for a specific, uniquely, individually made appliance for that person for what their issues were. So that was the beginning, and that was 27 years ago, I think. And he still comes to my office now only once every 3 months. He hasn't been taking new patients for many years, so we're finishing cases. But it was, there's so much that we've learned, in this field. Back then we weren't identifying tongue ties. It just wasn't being looked at and identified. And perhaps I actually think there weren't as many.
Well, let's back up in that, because there's a lot of juicy tidbits in there.
Sure.
As we were beginning the process and saying, you've got this. Was an endodontist, I believe.
Dr. Derek Nordstrom is a general dentist.
General dentist. Okay. So when he was coming into your office and he was developing in these appliances, so obviously there was a need for this. And what kinds of signs or symptoms were people showing up into your office with who were having issues for which this was the solution? What were they showing up with?
Well, the same issues that we're identifying now, which is facial growth discrepancies. Let's say the maxilla is back or the mandible's back, or they're both maxillomandibular protruded. It could be jaw joint issues, headaches. There were my patients that I couldn't get somewhere with the cranial, and they kept needing to be treatment dependent, let's call it. So they kept having to come back. They'd be great for 4 or 5 days after the treatment with their headaches or their neck pain, and then they'd come back. And then was like, let's look at how the teeth are coming together, because as the teeth are coming together is locking in those strain patterns.
Gotcha. And so did they show up specifically? I mean, what percentage, I'm curious, out of this were showing up as kind of routine, general kind of TMJ symptoms? Did they have that, or did they have the other symptoms and it was not at all obvious that it was coming from the mouth? Was that pretty common, or were they showing up with both?
Well, the patients, there were not that many patients that were actually coming in saying, I want the ALF approach. There were more my patients that I would then assess and determine that they needed this process, and then how to educate them about that. Because this is, again, 26 years ago, 27, whatever, where people didn't know about it. And they also then were patients from Dr. Nordstrom's office that he was needing to have a four-handed treatment with. So he felt that he was stuck. He needed some help. He needed some more hands-on, and then we'd collaborate together.
Okay. So so you had a combo approach of dealing with in the mouth and everything else that went along with it.
Because this is an appliance that is biocompatible, meaning that it augments the inherent motion that's present, and it augments intraoral function, helping to integrate it. So it's not doing, psychological thermodynamics. Every action in one direction has an equal and opposite reaction. So this is an appliance that was created specifically to not have a counterbalance consequence. So like with retrusive braces, you put the braces on the outside, everything goes back, the head goes forward to open the airway, because you're limiting the airway by volume decrease, pushing the tongue back. So then the head has to shift and change. So then to start looking at all the head forward posturing that were happening a lot of times with our teenagers, and they're slouching, and all the moms and dads are like, sit up, but they can't sit up because they can't breathe when they stand up because their head goes back.
Yes. So let's talk about that for a second, because in your book in particular, the ALF approach, so we spend a good amount of time on the front end talking about the development of the mouth and the cranium and the airway. And this is the idea, as I've talked about a lot of times, is, we spend so much time as practitioners working with people that have symptoms of just long-term structural imbalance and just stress of life and so forth, that you start to wonder, if you were to go back in time and actually address this far earlier, then maybe they wouldn't have dealt with such severe issues at this time, in which case now we're ultimately a lot of times managing them rather we are actually being able to fix them. So the development of the cranium itself and the mouth and the airway, let's talk about that for a second, and the proper development. And at what point does this start to kind of deviate and go into the direction that we don't want it in? Can you talk about that a bit?
Yes, I could probably talk about that for hours. Let me pare it down. So birth. The compressive forces that happen at birth are formative. When a tissue is compressed and restricted, there can be an asymmetrical growth that occurs from that point. And we really develop from the head down. We also develop structurally around function. So the function of eating, swallowing, breathing, and vision are the functions within the cranium that are going to dictate the formative, the unwind or the compensations for the compressions that happened at birth, let's say.
So we get squeezed, and then all of these things unsqueeze us, basically.
Well, we get squeezed, and we get squeezed in different ways, right? Everyone's birth is going to be unique depending upon the shape and size of mom's pelvis, whether there was Pitocin or not Pitocin involved, the strength of mom's pelvic diaphragm. So many factors go into the unique vector forces that occurred during birth. But what can happen is that, and this is really key, and this is a key point that is being missed, even within my own osteopathic profession, is that the occiput, which is the base of the head, this bone back here, embryologically, when we're born, it's in 3 pieces. And some of the pieces are, all the cranial bones, 22 bones are all floating in fluid, very much so when we're born, because we've got those fontanelles. So they're all floating. And the compressive forces, because the baby's head is what opens the cervix, those compressive forces go in, but they get stuck mostly at that occipital, the occiput and C1 junction, because that's the first cartilaginous joint within the cranium. And the occiput that's sitting on top of that, that's in 3 pieces, that connects with that first cervical vertebra, there's a lot of shift and change that can happen. And there are some vital cranial nerves that exit through the cranium out into the face and the rest of the body that are floating in fascia also. So you can imagine all this, all the knowledge we now know about fascial strain patterns, right, and myofascial release, that's happening at the baby's base of their head. And so one of the things that we can look at is certainly plagiocephaly. Plagiocephaly is kind of, and torticollis. Those are kind of more extreme black and whites, like this baby's in trouble, right?
So plagiocephaly, just for our listeners who are not aware of this, is the flattening, having a flat spot on the head somewhere with the baby, right? Which is pretty common, it appears now, yeah?
It's even just a misshaped head,
Yep.
not a round head, because it can be flat on one side, but it can be cone heads. Right. So the flattening can happen when the baby's spending too much time laying on their back as they get older. But at birth, the whole molding of the cranium tells us the forces that went into the baby, and can they unwind those cranial strain patterns? So what's really amazing, that's new information, is that one of the functions that unwinds cranial strain patterns is tongue function. So it's a proper resting of the tongue and the palate, and is a proper swallow. And a baby's swallow, and even a 2 to 3 year old swallow, is different than an adult swallow. And that transition has to happen to be able to continue to open our cranium.
Gotcha. And so, and right away, and mothers will be aware of this, is that we've heard a lot, at least, about problems with latching or the quality of the latch and those sorts of things. Is that where you start to exhibit signs of challenges with that tongue position and then needingness to train it? Or what do you start seeing this as first?
Exactly. So nursing, capacity to nurse, is the first step, is a first developmental stage that we're going to assess to see if they're going to have a functional airway. If they can't do a proper latch, if they can't do a proper second swallow, a lot of times mom thinks, oh, I had poor milk supply, but moms always think it's their fault. Yes. Our parents do, right? Yes. So it's not really the poor milk supply, it's the lack of stimulation to get the release. And that means that the tongue doesn't have its full range of motion and or its strength. And there are two different components that need to be assessed. And again, this is a key missing piece in lactation specialists and myofunctional therapists. That it's not just the range of motion of the tongue. So these tongues that are not functioning well, it's not just because they may be tethered, like this, tethered tongue, so they can't move. It could be that they have an impingement, an entrapment of a hypoglossal nerve, which is a 12th cranial nerve that innervates the tongue. And that's one of the important nerves, cranial nerves, that comes out right underneath that occiput, that again is in 3 different pieces with a lot of fascial connection. That is the area of greatest compromise during birth. So a lazy tongue that kind of stays down low, and even speech issues, swallow issues, chewing issues later on, this could be because of what in osteopathy we call occipital condylar compression. And these are the expressions of this is definitely difficulty nursing, but it's also the colicky baby. So if we have a baby that has got digestion issues, which is vagus, it has even mild torticollis, which is the 11th cranial nerve, the accessory nerve to the SCM and the trapezius, or they don't, and or all of the above, they don't have good tongue function. These are the babies that need to be treated right away and being able to release and open the base of the cranium to allow those nerves optimal function, because those nerves are very much involved in the development of the face and the airway.
Very good stuff. And one thing that comes to mind in here is also because of the complexity of how much this sounds, it oftentimes almost maybe has present as these are cases that are severely pathological or really obvious. And that may not be the case. So let me your input on this, but minor things, again, just a colickiness doesn't necessarily have to be these overt symptoms or obviously knowing that something is wrong, but they could be subtly present, right?
Yes, colicky from my perspective is a major issue because that's a clear sign that these nerves are not free to function optimally. But I would say reflux could be more of a, or spitting up. Let's take spitting up. We think of it as normal because it's common. But just because something is common doesn't mean that it's actually physiologically functionally normal. Yes. So babies should not be spitting up. You shouldn't be nursing them and them spitting up. It's either because the tongue isn't functioning well enough and they're swallowing too much air. And so then they have to burp too much because they don't have a latch. And it could also be certainly food allergies can be involved with mom may have to modify diet. But it also could be the vagus isn't functioning well. The glossopharyngeal nerve, the 9th cranial nerve is not functioning well. Those both have to do with the second swallow. So spitting up after nursing, a little bit maybe, but if there's an excess, babies should not be spitting up after they nurse. So that's another question that I ask when I'm seeing, and I actually ask these questions to adults when I'm seeing adults for TMD issues. I always ask a birth history, always, and a pregnancy history too, because it gives me an insight into maybe how chronic this issue is. Did they grow with this issue? Or is this like a traumatic, they were in a car accident, whiplash, jaw hypermobility, and that's when I'm dealing more of a structural traumatic issue.
Yeah, and all of these things, and this comes to mind, the process that happened with my son is that when my daughter was the firstborn, she generally had no problems, and we laid her in her crib and, perfectly nice rounded head, didn't seem to have any of these problems. But my son was a different animal. We had him, and he liked to sleep in this kind of, I forget what we call it, but it was a certain kind of oval shaped or rounded sleeper, and he loved this. And not as much rolling. And we started to see some flatness occurring on the back of his head. And he was a constant spitter upper. He was constantly spitting up. And this was becoming a concern that there was reflux, et cetera. And again, as parents, and even somebody who's kind of in this industry is, you're not around that. That's a very specific specialty. And all we kept getting was the same, well, that's fine, he'll grow out of it, or keep him more upright, and which further facilitated keeping him in that. And the flattened part of his head and spitting up. We had such a challenge with this. And then again, from an evaluation standpoint, as we would go in and saying, hey, maybe we should do something here, because in particular, I'm concerned about his oral development because of the flatness of his head. And again, we just kept getting the same dismissal. It's fine, it's cosmetic, it's not a problem. But I knew that this is going to be a problem at some point. Mm-hmm. And yes, he did grow out of the spitting up, and that did eventually stop. But then we get stuck in this phase where it's now about his cranial shape. And is it going to get better? And we're starting to see changes in his jaw and how his teeth are fitting together. And the solution is, what it is, stick a helmet on him, and that's just going to force everything straight. And we just kind of know that is not a great answer. And is that something that you see a lot? It's just, there's a lot of dismissal. These things don't matter, and it's just cosmetic.
Yeah, that is still the word that's out there in traditional medicine. And it's just simply because they don't know what else to do. They just don't know. Most of them are good people. Most of them care. They're just not educated. They're not getting the training that they need to have an insight into what the actual issue is. So how old is your son now?
My son is now 3. He's going to be 4.
Okay.
So I'm still... Okay. And there's another big side of motivation for me to interview to talk about more about this, because the process of that I think is going to be helpful. I think he's young enough, I would imagine, to still be able to strongly influence these factors, and be able to have a successful outcome before things start to kind of solidify themselves.
Oh, for sure, for sure. 3 and
Yep.
4-year-olds quite young, and it's what a blessing that you know what you know, so you can help influence his growth and development from this point, forward.
Absolutely.
60% of the facial growth is complete by the age of 6 years old, but the cartilaginous joint within the middle of the head doesn't really come together. It doesn't so much ossify. It still has a flexion to it, but it's not cartilaginous anymore at 28 years old.
Wow. So we've got some time.
Yeah.
So let's talk real quick about one thing you brought up that I want to talk a little bit more about. So we talked about that tongue being able to sit across the roof of the mouth.
Can I circle back around? Because there's something
Yes.
that you said that was really important that I really want to connect with you about. So especially for the work that you do. So one of the things that may have happened, and I haven't had a birth history or, a history of your son or anything like that, from just what you're saying, what caught my attention is that we have so many of our babies are in these, C-shaped, let's call them C-shaped, right? The car seats are C-shaped. The bassinets can be C-shaped. And what that does is inhibit core muscles, and it brings the head more forward in that head forward posture. If they've got restrictions at the base of the cranium, that's a hard place to go. They don't have that. When you bring them forward, they're going to go into more of a strain pattern at that base where the occiput meets the C1. So that most likely was part of the issue. So I tell, as much as we can, we want to not put our kids in these C-shaped experiences. Again, that just leads them to growing in this head forward posturing. And again, it inhibits the development of the core muscles, right? Because you can imagine it just bends it like this. So the rectus abdominis just gets shorter and tighter rather than having an expansion contraction, which is actually strength.
And that's what everything is made. I mean, if we go to Target, you go to Walmart, whatever, you just look down the baby aisles, everything is that. So you're meant to almost believe and accept that that's just normally how it goes.
Absolutely. There are some car seats, I think, out of Europe, that Europe, of course, is always been a little more forward thinking in terms of an integrative approach that you can get that are more upright. So just for the moms, for the parents that are, have their kids in these C-shaped, car seats, that's one thing we can do to try to help.
I feel like this could be an entire book. And of course, I feel like a lot of links are going to be produced at some point underneath this video as well. So let's talk about that, the tongue position on the roof of the mouth and what that's actually doing, and the inhibiting factors. One of them you mentioned, which was called the tongue tie. Can you explain a little bit more about those two issues?
Yeah, so the face, again, grows out from the base of the cranium. So when we're born, we're mostly cranium and a very, very small little face, because what grows the face is the functions of the face, and it grows down and forward out from the base of the cranium. So strain patterns back here are going to dictate some of the growth that happens through here, but also all of this and how these are functioning, how our eyes are functioning. Are we doing nasal breathing? Do we have a good lip seal? Is our tongue up in the roof of our mouth? And do we have a good up and back swallow? Those are the functions that really create the face and actually dictate the position of the teeth. So we used to think that, teeth position was more of a genetic, but now we see absolutely not genetic. It's epigenetic. Epigenetic means that yes, we have a certain amount of DNA that potential, but what's turned on and off depends upon our environment, right? So it's what we eat, how we swallow.
And I was going to bring that up, is that first of all, it's dramatically obvious when you look at the cover of the book, because this was a significant factor, is the development of the face, especially obvious from the side. And this brings back the idea that I think a lot of people in the natural health field are very familiar, hopefully at this point, with the work of Weston A. Price and nutrition and physical degeneration, where he talked about traveling to a lot of countries and looking at indigenous cultures and seeing that their facial development was dramatically different and far less problems with their dental structure and their teeth and shapes, or teeth not growing in crooked and so forth. And they were dramatically different than what he was seeing in cultures like in America.
Yes. And there's a whole chapter on that in the book, because what we eat is what we are. That's a large part of the nutrients that we have to form our structure, but also specifically in the face, we're going to definitely see structures that express how we've been using our jaw. And since the industrial time, it's just kind of been downhill in terms of optimal facial growth. Our food got softer. And now so many of the kids, and I get it. I was a working mom, with 2 kids. I get it. But, you pass the yogurt. They didn't have this when I had my kids, but now they have these yogurt things that you pass back, or these, things that, and the children are not chewing anymore. They're not using their jaws. We're not chewing on bones, not necessarily, the kids have to chew on bones, but anything that's hard, as long as they're old enough and they have a functional enough tongue to be able to chew and swallow, but we're not chewing. And so our mandibles are less developed. And you can see the progression when you look at the forward growth of the face, it is much less. And now what we're seeing is, we call it bimaxillary protrusion, where both the maxilla and the mandible are actually further back. And it's a simple way to test. You can actually just take a measurement from the outside of your ear here to the outside of your eye here. This distance from here to here should equal the distance down here to here, right? So at least that will tell us, are the maxilla and mandible relatively growing together? Now, they still could be further back, but that's like one simple little screening process that parents can do to see, how, where are we at in terms of growth and development of the face.
Gotcha. And so in particular, that tongue position going up, right? And we want that to go there to try to push that open and create some more space. Yeah. You've got this tongue tie situation. What is a tongue tie?
A tongue tie is actually an embryological malformation of the tongue, that in utero, there's tissue underneath the tongue, which is considered to be a midline structure. Let's just do it like this. The tissue underneath the tongue here is supposed to go through apoptosis, which means it's supposed to resolve. It's supposed to die off. And then we have more of a range of motion of our tongue. But for whatever reason, and I have my thoughts on it, which I think it has to do with 2 main components. One is that I think the toxins, the biotoxins that we're exposed to, and the potential an MTHFR gene, which is a gene that is, if we have don't have enough of a enzyme that functions in the liver to detoxify, then we can have a developmental process that gets stalled. And so this doesn't get reabsorbed. The other is very interesting, and there is studies starting to happen around this. And I find it makes so much sense to me, even though we don't have, evidence base behind it. But that is that if mom's airway is compromised, so if you've got mom with a long face, open mouth breathing, doesn't breathe through her nose, the womb is having the same oxygenation issue as she is having. And so the structure of the baby is formed within a lower oxygen containing environment. And so that's when we see these babies with their mandibles way back, retrognathic, but also the tongue doesn't have its full range of motion. And so the ties aren't being resolved within utero.
Gotcha. And so what I was taught in particular, the challenge is, and through places like the Postural Restoration Institute, through their studies, the problem we see is not being able to optimize and influence these things as best we can by that critical point that seems to be, especially here in America, at roughly around age 9, where kids go in and start having their teeth inspected and looking at everything from a cosmetic perspective to get braces, and essentially, for a lack of a better way of putting it, locking them into their dysfunction, what I was told. So do you see it that way? And so literally at this point, the purpose of using braces and so forth is try to force the teeth to look straight for cosmetic purposes. But what is this doing for all of that stuff that has already been occurring?
That's right. That's absolutely right. So 9 years old is still a great time to start the ALF process. So, as soon as we can get them in the chair and be compliant, and they've got molars that we can attach the appliance to, we're kind of good to go. So we've had patients 4 years old, 3.5, start with the ALF appliance, and it goes so fast. It just catches them up and gets them in that normal growth and development process, and they're pretty much good to go. The issue is that if there is dysfunction in the teeth and how the teeth come together, we know that there's a myofunctional issue. We know that there's something not right with the tongue, or there's something that's not right with the swallow, or something not right with the breathing, or something's been, and a reason for that could be the compression at the base of the cranium if we're talking about children. So when you just take the teeth and you move the teeth around, and then again, dentin is the most is the hardest substance in the body, it's going to win. So how the teeth lock themselves in will again lock in those cranial strain patterns, because the teeth are merely the position of the teeth are merely an expression of the soft tissue and the functionings of the craniofacial complex. What we don't want to do is take those teeth out of what their natural integrated position is and reposition them. So we want to unwind the cranial strain patterns first, get the intraoral functioning, get the lip seal nasal breathing, and bringing the teeth into alignment is the last step. It's what stabilizes it all.
And what you had mentioned in the book as well is that one of the evidences that it appears of this is that once you get braces taken off, you're not done, because unless you wear that retainer,
that's right,
things will continue to progress in the pattern based upon the way that those soft tissue issues and cranial strain patterns has initially presented themselves as.
Exactly. So there's 100% relapse in traditional orthodontics if you don't wear your retainer forever. And that should be in question. You know, that's really interesting to look at. Why does the body want to put that out of alignment? So it's not genetics that are just pulling it out. Genetics don't work like that. So the question is what are the soft tissue influences that are bringing the teeth into a different position? And I use that as kind of like a treasure hunt to try to figure out what the issue is. For example, if they've had braces and they're an adult and now they have crowding down here, which is very common, and they're having gum resorption down here, which is very common, I look at how they're swallowing and I look at how they're chewing and get a sense of why those teeth being moved again. And well, almost always in that situation, it's an anterior tongue thrust, where instead of the tongue is still acting as if it's nursing, it's going forward and back, forward and back, forward and back. It hasn't transitioned into the adult swallow, which is up and back. So when the tongue goes forward, the muscles here have to contract so the food doesn't come flying out. And this muscle here called the mentalis overcontracts and it rubs on the gum tissue lower here and it wears it down and gets thin. So instead of getting gum surgery, which is what's recommended, I look at where the wear and tear is in the mouth with the gums. It could be up here, which means they could be doing something like that, stabilizing their mandible when they're swallowing.
I'm laughing because oftentimes the explanation, and we see this in the physical movement realm as well, is imagine somebody hitting their head up against the wall and saying, well, my head hurts. And the traditional kind of approach right now is to put a sponge between the head and the wall rather than actually stopping the person from slamming their head up against the wall.
Right.
So it just seems like everything is about this just kind of palliative care to try to remove the symptoms without focusing on root cause. And I will bring up one additional thing here, because how this integrates with the work we see is that people have to understand that these cranial strain patterns and asymmetrical patterns continue all the way down the body. And we have more and more problems with this as being naturally asymmetrical from the start. You have a heart on one side and the liver on one side. Then on top of it, we're usually most often, of course, right-handed dominant, and we live in a world that supports ease for right-handed people. So now we're just locking ourselves into these asymmetrical imbalances, and they're so prominent and they just are so presupposed that we don't even know how to recognize them, which is very, very common in the movement field. And in particular, I see this manifested as when people do physical assessments on patients, they look at imbalances if they can all exist just randomly. And they don't exist randomly. The body has reflex patterns that if this muscle is tight and you pull your body this way, you should see a positive test on another part, and et cetera. So it's fairly predictable, which is amazing that for myself and my colleagues, we sit back and wonder why people don't see this. And they're just so removed from even the thought process that these things manifest early on and just continue. And then we have injuries and so forth that occur that change things. But there's an inherent pattern that has been going on all the way from the beginning. And I think that's in particular, which is causing a strong movement of practitioners to be interested in the work that you're doing, because again, we want to know where this is all starting from and what is the underlying pattern that drives this. And the reason why some of these corrective exercises and therapies and so forth don't stick. And because everybody starts to realize at some point, are we dealing with symptoms or are we really getting to this theoretical root cause? And that seems to be always the question.
Yeah, it is really interesting. I mean, we haven't developed asymmetrically. No, we develop, again, epigenetics based on our functions. And our functions include how we sit, mousing, right-handed, left-handed. Do we have a good midline development? Can we do cross patterning as a child? Are we developing that midline that's supposed to come in around 9 years old neurologically? So it's wonderful that we can see a predominant pattern that happens with people, but it's so much more complex than that. From where I'm looking, where I'm treating, I have to assess the individuals as an individual, and I see the individual having their own pattern in terms of unique river, and that river and flow of that river is going to create a unique riverbed to it. So it's looking at what is the pattern for this individual and what is the predominant obstacle to whole body integration. So that's just in addition to what you're saying.
And paying attention to patterns. I think that's the thing that's always the most important component for me, is being able to step back and then to say, what else is included in this? What else is included in this? Mm-hmm. And of course, it stretches across the whole biopsychosocial sphere. Influences such as nutrition, of course, psychology being the result of, and perhaps even a contributor to sometimes. But I think we're all on the same playing field here. What I do want to talk about, because we've mentioned it many times, I'm sure people are ready for this, but let's talk a little bit about the ALF appliance itself. Okay. And you alluded to what it is. How is it used? And in particular, what does the general process look like when you're using this kind of appliance?
Yeah. So the rate limiting step in this whole ALF approach is getting dentists who are well-trained in the ALF approach. That is the most difficult part, is to find an ALF dentist in your area who's well-trained, because they don't have to be trained in the ALF to put it on their website. And so unfortunately, since it's getting to be more and more of a, it's getting more and more known, the ALF, then dentists will put it on their website, and then they come in and then they say to the patients, well, that's, the ALF won't help you, but this, BioBlock will, or a rapid palate expander will, and so forth. So unfortunately, that is happening more and more. There are places, I would finish the sentence. So there are places to look for dentists who have taken courses, and there are different teachers out there. So there's slightly different perspective happening. My website has a list. ALF Orthodontics is a website that has a list. Dr. James Bronson has a list. These are places that are going to have a list of dentists who have taken courses. So the dentist is the one that does the evaluation, creates the design, implements the upper and lower light wire. It's a very, very light wire that goes behind the teeth, the upper and lower teeth. It does not inhibit the tongue. That's one of the reasons. That's what Dr. Nordstrom wanted to do, was to create an appliance, a dental appliance that was cranially friendly, that was actually holistic and integrative. And so in that way, because it's a 24/7 myofunctional appliance, because it's attracting the tongue to go up, it's also the kind of wire that it is yellow alloy wire, and it has a give to it. So it took Dr. Nordstrom a long time to perfect the kind of metal. And the reason why this metal is so important is because it has a give to it. It has a flexibility. So when we swallow, we're supposed to augment our cranial motion when we have a functional swallow. This wire augments that cranial motion every time you swallow. So now you're getting an unwinding of the cranial strain patterns 24/7. And it's also an orthodontic orthopedic appliance because it will move teeth. But the very first phase of it is not moving teeth. The first phase of it is the unwinding process. We're trying to unwind and integrate the root causes of why the teeth are in the position that they're in. We don't start closing down. So we get the expansion that happens. But if a dentist uses it as an expansion appliance, it doesn't go well, because it's a light wire, and a little tiny bit of adjustment makes a large difference. If you adjust it too strongly, you lock down the tissue. It's that property of thixotropy, which is a property of all colloidal models, that the tissue responds and either yields or doesn't yield depending on how it's acted upon. So if someone comes to you and gives you a great big hug, you're going to have a melting feeling, as opposed to a pow, you contract and the tissues get hard and tight. So if they use the appliance incorrectly, it doesn't give the results it needs. And that's why the training process is so important for them to go through, to understand the osteopathic principles that are behind the ALF adjusting.
So I can imagine there's two additional components that are important. Is number one, probably a constant readjustment, probably like many things, right? So it's carried out over a period of time with tweaking. But two, the addition of other therapies, cranial osteopathy, any kind of manual therapies. And this is where my interest is working with clients, dealing with some of those patterns that might be contributing to this in lieu of the work that they're doing there as well, to try to get the maximal effects.
Mm-hmm. Yes, it is. It's in the beginning stages, it needs to be adjusted once a month, because what's happening is there's a three-dimensional expansion that is happening, and the appliance could even fall out or get loose on different sides, depending upon how it's affecting tongue function, how it is adjusting. Maybe it's adjusting more on one side than the other side. And that also tells me as a cranial osteopath, where are the restrictions? Because it's an indirect appliance. It's not going to push, it's not a bully. It's not going to push through the tissues. So how it is developing tells us where the restrictive patterns actually are also. It's just an indication. And yes, the collaborative approach is very important. Myofunctional therapy is a very important component of this approach. When we see a tongue tie, they go straight to the myofunctional therapist, and it's my myofunctional therapist who tells us when they're ready for a frenectomy or if they're going to get one. And we have other ways. In my office, we have something called a laser 1064, which helps to release the muscles and the fascia underneath the tongue. And it helps to integrate the suck swallow neurology. And so it's something that we can use right away in babies. So if there's a questionable tongue tie, we can a lot of times get them functioning just using the laser. It doesn't cut tissue. It should just feel warm. It doesn't hurt babies at all, or adults. So there are different modalities that we have to try to optimize the tongue function, but myofunctional therapy, cranial osteopathy, and the ALF dentists in general are kind of the three stools of working in this approach. And then also the other manual therapists to help with everything else also. But the cranium definitely needs to be treated. In adults and complicated cases, the cranium definitely needs to be treated in this process. And the process itself of the ALF approach goes about 50 times faster when you've got the cranial osteopath on board. So that's a price point difference for parents a lot of times, because in the beginning, who do you see first? It's a resource issue also. Not everybody can afford to see everybody. So who goes where in that triage is also an important aspect to assess.
Yeah, and that's something that is always an issue. And this is a larger discussion, of course, which is managing multidisciplinary care. And the challenge is that you're right. I mean, that's the thing. So who goes first, and in what order are things done in? And in particular, again, finding those resources. And the challenge is in trying to educate people on, if you're seeing one practitioner who just wants to stick an orthotic-based appliance anywhere in your body without any supplementary care, there's probably something wrong with that. And you should be skeptical of that, because this stuff requires having to have multiple practitioners with different specialties addressing the things to keep the therapy moving forward. And I think that's a big issue. So I have two additional questions here when it comes to appliances. Number one, those of us who are parents know how challenging it is with little ones. And in particular, I've taken my son to see a cranial osteopath. He cried the whole time. It was very hard to get him to stay still, and a little bit nervous about taking them to a dentist to have this, because number one, getting him to sit still, two, having this appliance put in his mouth, and how does he respond to that? And I know that's going to be such a variety of things, but what has been your experience in using the ALF appliance with very young children? Is there an ideal point in which you're going to go for this, or do you try multiple times, and whenever they can lay on the table and accept it, then they get it?
Well, thinking about for your child, a 3 or 4-year-old, there's so much to do before we get them to the ALF. And even if they need the ALF, they're still young enough where there's a high probability that we can get them functioning well without needing the ALF. That's young. So, and in terms of it is also dentist dependent. Like there's some dentists, like a pediatric ALF dentist, right? They're going to have a lot of skills on how to work with the little ones, right? So it depends upon the skill set and even the social IQ of the dentists of how they're going to work with little ones. In my office, I treat lots and lots of little ones. It's actually never a problem. I've even treated before, a kid was super, super, super ADD. And the only time he was quiet was in his car seat. So the parents drove me around town for half an hour and I was in the back seat treating the kid. Like there's a lot of creative ways. You got to be super creative with the kids. I've treated kids like curled up underneath the table. I've treated them in their mom's arms or dad's arms the whole time. So you have to be creative and you have to get that connection going. And they can sense and feel, they can sense and feel like, oh, this person is trying to help me, maybe I like them. So, and sometimes it takes one or two treatments to get that warmth going. But inevitably they all end up on the table, falling asleep. So,
adaptation.
Yeah. So you just stay with it. And you basically, what happens is, this is the parenting in general, is you work with what's working. You look with what can they do? What are they comfortable with? And you start working with what is working for them, and removing obstacles.
And so the next question I would have is a two-parter to that, is that you've got the young age, and you say that, there's a lot to do before that, before you may even get to the ALF appliance. Now, is there, on the opposite end of that, is a range where the ALF appliance becomes less useful? Is there an age or, at a time where you're not even really going to focus on that? You're going to focus more on other things?
I would say, 70s, when I have a patient, I've treated patients in their 70s and some of them with the ALF, and actually they do quite well. It's a health supporting device. So we just use it. We kind of think of it a little differently. We're not trying to necessarily expand, push things or get things open. What we're trying to do is support the base of the cranium to open. We're trying to get that intraoral function still happening. We're trying to get some optimal breathing. A lot of times we're working with sleep apnea, right? So now I have a new laser called a Photona night laser, which is truly amazing. And that tightens the collagen tissue in the posterior pharyngeal area. So, it's having lots of different tools to use depending upon what the needs of the patient are and what their complaint is. And so you can get an ALF when you're in your 70s, but it's not going to be that we're trying to, and there will be some shift and change in the teeth for sure. But the expectation is going to be different than when working with a 5-year-old.
Gotcha. And so, there's so much here. I think we could go for another hour continuing to kind of delve into all of these topics, but I think we've got the core essence of, number one, how many different things have been generally, I would say, completely unexplored for the most of the time with people. Great opportunities for parents to start educating themselves before these things or as these things are starting to present themselves, but also the ability and the utility of using these devices, and obviously approach up until 70 for different reasons, but there's options and there's things that people haven't explored. So are you finding that dentists and odontists and so forth are starting to come around to these ideas a lot more? Obviously it's spreading, and it's for the reason for writing a book, but are they seeking out more training and getting more interested in these topics? Definitely.
It's really interesting. So I reflected how I've been teaching basically the same thing. Everything is a new concept is always growing, right? So I've been learning and growing and learning and growing for the last so many years, but basically teaching a lot of the same concepts 20 plus years ago. I would say I probably started teaching maybe 25, 24, something like that years ago. And I would remember finishing a lecture and I'd look out at the participants, mostly dentists, and their eyes are just blank. And I'm like, I don't think it's getting through. And now when I teach, the eyes are popping. They're doing this. I just finished I have an online course that I teach, and then I do Zoom meetings for question and answers and discussions. And so this way I can reach out internationally. So I had a group of dentists and orthodontists from Europe. Now I have some from Australia reaching out, and they're like, wow, they get it. They just get it. And I think it's because one of those things of the story of the 100th monkey, the exponential curve, when enough people know about something, with enough monkeys figured out how to dip their banana in the ocean to get salt on it or something like that, all of a sudden it crossed over to another island,
Yes.
So we're at that place of exponential. We're right at the bottom. And that was definitely a big motivation for writing the book. The other part, I needed to just get this out of my head and on a piece of paper. But we're about to explode with a whole paradigm shift in how we're approaching craniofacial dysfunction, malocclusions. And we need to get more dentists because they're going to be getting parents in asking for this.
Well, I want to be a big contributor to that by pushing your book out there to as many parents as I know and getting this information out there, and for the purpose of the podcast. As you know, most of my listeners know, the reason why I do this is to seek out experts in some of these topics that is very hard to find information on and introduce them. But then the next logical step is to read the book and then to start seeking out resources. As we generally as a population start forcing the hand to say, this is what we want, then we're going to have a response to that, to more practitioners who are going to respond to that demand and get the proper training to be able to help us in the direction that we want. And I think that's really, really important.
Yes, absolutely. And I'm very committed to getting the word out too, and love teaching, and feel grateful that there's an ease of flow that's opening and happening already.
Absolutely. And so I don't want to take up too much more of your time here, Doc. Thank you so much. But let's find out a little bit more. So you got your book, which case I'll link to that below so that people can get access to it. Anybody, but parents in particular, I'm really heavy-handed with the push on that. Anywhere else where people can follow up with you? You've got some awesome YouTube videos. I've already checked those out with a lot more detail, and in particular pictures, which a lot of the stuff that we had talked about, but you show a lot of images about this stuff too, which is pretty awesome, with very, very impressive changes with before and afters and so forth. But where's the best place to keep up with you today?
Gosh, I mean, the website has information. I'm hoping, I'm focusing on teaching out with dentists and osteopaths and myofunctional therapists. I'm teaching in Washington, D.C. this weekend and back again next month. I don't really know.
I think the website and YouTube is where I was following up on your stuff. But I'll look you up for those things to make sure those there, and of course the link to the book too. But any final thoughts that you want to give the audience?
Yeah, just hats off to the parents. It's challenging being a parent in this time and this age, and there's a lot of new issues that come up with our children. And I'm hoping that as these new issues come up, that universe is providing solutions, and the ALF approach is definitely one of those solutions. And hope it's helpful for many, many people.
Absolutely, and we'll make it so. So, Dr. Turzo, thank you so much again for being here. Everybody, listeners, thanks for listening again, and you know where to subscribe and to watch for the next episode. So I'll see you next time.